And I'm very happy to have the opportunity to introduce this exciting meeting with the presence of three dear friends who are recognized international experts in the field of acute myeloid leukemia and transplantation. Professor M.Mothy is the head of hematology and cellular therapy department at the Saint Antoine Hospital of Paris and Sorbonne University of Paris. And he also the chairman of the Acute Leukemia Working Party and past president of EBNT, the European Society for Bone and Marrow Transplantation. A.Nagler is the director of the hematology of bone marrow transplantation and cord blood transplantation at Sheba Medical Center in Tel Aviv, Israel. And he was one of the pioneers of reduced intensity conditioning. And finally, Giovanni Martinelli is a full professor of hematology at the Bologna University. He is also the scientific director of the Istituto Scientifico Romagnolo per lo studio della cura dei tumori of Meldola. He is also the PI of an important financed international project, Healthcare Alliance for Resourceful Medicine Offensive Against Neoplasm in Hematology, so-called Harmony. So, my task today is to introduce the meeting with a few slides, and if you want to summarize the many hot topics in this area in a few slides, we could design two main scenarios: a pre-transplant scenario and post-transplant scenario. I have no time to go into detail for each of these hot topics area, but starting from the first topic, which is the donor choice, we can synthesize this aspect with a sentence that everybody has a donor. I could say everybody has a good donor. There are a lot of retrospective comparison. This is one of the most important series comparing haploidentical transplant with a post-transplant cyclophosphamide platform versus the conventional transplant in match-related donor or match-related donors. And as you can see here, both non-relapse mortality and relapse incidence were absolutely comparable with similar outcomes in terms of leukemia-free survival. This very large series from ABNT encompasses about 1,600 ML patients who has been transplanted with active disease. And as you can see, also in this case, regardless the kind of the donor, comparing match-related donor versus haploidentical transplant with post-transplant cyclophosphamide. As you can see here, all these patients had a similar outcome, but the most important final message is that whatever the kind of donor source, allogeneic transplant can rescue about 20–25% of ML patients with advanced disease, and this is a very important message. So, as you know, many experimental evidences suggest that the relapse is linked to the persistence of few leukemic stem cells and is correlated with MRD positivity. So we can operationally define from a biological point of view the MRD positivity, such as the presence as a good indicator of the presence of few leukemic stem cells persisting in the body, which have not been eradicated by chemotherapy. And this a very large systematic review shows that whatever the kind of MRD detection, multiparametric flow cytometry or molecular probes, the outcome after allogeneic transplantation was significantly worse when a patient has been transplanted with MRD positivity. But the MRD status is not only an important prognostic indicator, but it can also be used as an important tool in order to plan the kind of conditioning. As you can see here, only myeloablative conditioning and not reduced intensity conditioning was able to significantly improve the leukemia-free survival in patients with MRD positivity before transplant. As you know, this is another important hot topic. The allogeneic transplantation is the only tool able to warrant an opportunity, a chance to long-term survival for older patients fit for allogeneic transplantation. And as you can see here in this prospective series, that despite the higher non-relapse mortality, the overall survival was significantly superior for patients who received allogeneic transplantation when compared to patients receiving conventional chemotherapy. But how to select all the patients fit for allogeneic transplantation? Several scores have been proposed, such as the old ABNT score, the more recent SOR score, up to the more sophisticated tools such as the endothelial activation and stress index called E6 and composite indicator disease risk comorbidity index. But the problem is that we are still losing too many patients on the road to allogeneic transplantation. So, as you can see here, I'm not trying to go into details, but the speakers following will go into detail on this aspect. Many new drugs have been demonstrated to be able to work as a bridge to allogeneic transplantation in order to widen the number, percentage of patients potentially candidate for allogeneic transplantation. So, coming from the pre-transplant to post-transplant scenario, and the main focus is, and the so-called $1 million question is there is an effective graft versus leukemia effect? So the answer, yes, it is, but we have a very difficult problem in order to quantify the magnitude of effect, because there is a clear gap between biological demonstration and clinical finding, mainly due to mechanism of immuno-escape. For example, escape which has been demonstrated by elegantly demonstrated by the paper by Luca Vago in the APLO setting. But there is also an important aspect linked to the discrepancy between the fast growth of leukemic burden after the relapse and the relatively slow amplification of effectors after immunotherapy. So in the selected patient relapsing after allogeneic transplantation and not showing a graft versus disease, as you can see, both allogeneic transplantation, a second allogeneic transplantation, and donor lymphocyte infusion have been tested, but as you can see here, the long-term survival in this patient is very poor, and there is no apparent difference between these two kinds of immunotherapy after bone marrow transplantation failure. So, besides immunotherapy, several new drugs have been tested in patients relapsing after allogeneic transplantation. I have no time to go into detail, but the speakers who will follow me will go into the details. And also post-transplant maintenance have been explored, and this is an example of the setting of patients with FLT3 positive leukemia, in whom the administration of specific TK inhibitors can be effective in the maintenance. So the problem and the topic of post-transplant therapy with target drugs, which could be MRD driven, is very important now. So in conclusion of this, my very short presentation, I had some problem, but it was the last slide. Anyway, I stop here my presentation, and I'm very happy to introduce Giuseppe Visani. We will chair the next session. Thank you.
Thank you, Attilio, for your nice introduction that shows many aspects of what we are going to say this afternoon. And now I have the pleasure to give to Professor M.Mothy, that was perfectly presented by Attilio, that will give us a very important tool, that is the stretches that bring to transplant. That is one of the most hot topics in transplantation for AML today. Thank you, Mohammed, and now the word to you.
Thank you very much, Giuseppe. Thank you very much, Attilio, for the kind introduction and for setting the stage. I think in 10 minutes you have summarized 40 years of research in the field of transplant for AML. It is really a great pleasure to be part of this event and to share this meeting with this distinguished faculty. A big hello to all my Italian friends. I hope that we will be able to meet very soon in person. It's good to have Zoom to keep connected, but it's much better to be together and share a nice lunch or dinner and a good drink. But hopefully this pandemic will finish very soon, and we'll go back to some nicer time. So my task as part of the meeting is to give you a sort of an overview about some of these strategies to bridge to transplant, but also, as alluded to by Professor A.Olivieri, the issue of the post-transplant treatment. My disclosures, but nothing relevant to this talk. I don't think I need to spend a lot of time to convince this audience about the very poor prognosis of patients with relapsed or primary refractory AML at the era of chemotherapy. These patients, unfortunately, are going to die, and the only valid option we may have, you will see, is probably the allogenic transplant procedure if they have a donor and have suitable fitness. But let me walk you through first through what someone would call the magic bullets in AML. I think it's a very exciting era for acute myeloid leukemia, but also acute lymphoblastic leukemia, although my focus now is about AML, because after 40 years of stagnation, living with 3+7 and with low-dose Ara-C in the elderly population, now we have 9 new drugs approved by FDA. Of course, they may not be approved or reimbursed everywhere in Europe, but still, this is very exciting. And you can see the landscape is quite amazing. I mean, and I don't know if every single drug you can see here will make it into the clinic, but definitely you can see that the portfolio of drugs is very rich and is giving a lot of hope to patients. One example, I think, of the drugs that were really rejuvenated in the last few years is gemtuzumab, the drug conjugate against CD33. And this drug, if combined with a classical induction before transplant, This is what Professor A.Olivieri alluded to, the pre-transplant scenario. Well, definitely you can improve the survival of the patient, as it has been published in this French multi-center trial in the Lancet in 2012. Another attractive and important drug is this so-called CPX351 or Vyxeos. So this is a very fancy drug because it's a sort of a 3+7, but with a very attractive, safer, and more effective delivery process using the liposome. And now it was initially published in 2016, but now the drug is approved in Europe and elsewhere. And actually, you have a survival even advantage when you compare it to the classical 3+7, for instance, in secondary AML. So clearly, these are very attractive drugs in the pre-transplant scenario. Nevertheless, none of these drugs that I have mentioned is able to cure the patient when it comes to relapse refractory AML. And this is where we continue to believe that the graft versus leukemia effect, the immune-mediated graft versus leukemia effect, remains the most powerful anti-leukemic tool. And you may remember, this is now more than 40 years ago, the publications from Seattle, Paul Wyden and colleagues, Rainer Storb, Don Thomas, showing, for instance, that the patient with the allogenic effect, and this is moderate graft versus host disease, are going to enjoy the longest survival. So we should never neglect this treatment option for the patient if you can find a donor. And we heard from Professor A.Olivieri today that thanks to the haplodonor, the match-related donor, the unrelated matched donor, but also maybe cord blood, putting all this together, actually, you can find a donor to most or the majority of the patient. And if you can find a donor to the majority of the patient, especially in relapse refractory AML, we should not neglect this option. And we really have been working hard on further refining this platform from Professor Kolb and Christoph Schmid from Munich in Germany. And this is now 15 years ago. The initial publication was from 2005 and 2006, where they have pioneered this sequential Flamza-like approach. So the idea is when you have a relapse refractory AML, maybe if you have a donor, then we can give a sort of a strong cytoreductive chemotherapy. And initially they have used fludarabine, Ara-C, Emzacrin, followed immediately after 2 or 3 days of rest by conditioning regimen. And initially they used TBI, 4-gray and cyclophosphamide, but also they have used systematic prophylactic or adjuvant DLI. And to make a long story short, what they could show in the initial publications with refractory AML, with a relatively decent follow-up, you can achieve something like around 40% of 2 years overall survival. And this is huge if you consider the refractory patient, where with single agent, with the novel agent, you wouldn't expect more than 10% survival. So, and probably many of these patients are being cured. We tried to improve this platform of the Flamza by replacing fludarabine with clofarabine, because we believe clofarabine has the same properties like fludarabine, but it has also some additional anti-leukemia effect. And we have replaced TBI 4-gray by IV busulfan, 2 doses, so sort of a reduced toxicity. And we published, this is multi-center national trial in France, published 3 years ago, and we are currently updating these results. But what we could see in the primary refractory population, you can achieve 46% leukemia-free survival at 1 year and almost 30% leukemia-free survival at 2 years. And we are currently updating the results with longer follow-up, and it's not published yet, but the results are quite stable. So this is really good news, because it means even in the relapse refractory setting, you are able to cure patient with long-term follow-up. And more importantly, if you look to the transplant-related mortality, it's around 10% between 1 and 2 years. So really, the approach is feasible, even in a multi-center fashion. More recently, we have introduced haplodonors in this FLAMSA-like approach, because in the previous trial, we have focused on sibling and 10 out of 10 unrelated donor. So here we have developed a platform that would allow to use haplodonor. And we know that engraftment, when it comes to haplodonor, can be problematic. This is why we modified the original chemotherapy to introduce thiotepa, because we know thiotepa is very important in the conditioning prior to a haplotransplant. We also wanted to widen this platform into lymphoid diseases like ALL or refractory lymphomas, and that was before the CAR T cells, and fludarabine busulfan. And we use PBSCs, and of course, if you're using a haplodonor, we use cyclophosphamide, the post-Cy after transplant. And we have published the initial results in 2018. And if I focus on the AML patient in this study, and we had 44 AML patients here, all of them refractory, complex karyotype, high risk. Some of them received, that was the second transplant. You can see that the results are quite impressive. The follow-up was quite short when we published this, but now we have longer follow-up, and we hopefully will be able to publish this also very soon. Dr. Duleri is writing the update, but clearly we have very impressive, roughly 40 to 50% longer survival. So clearly the transplant in the high-risk relapse refractory patient using this kind of sequencer regimen is very important. But I believe we can even continue to improve these results. So these results, even in the relapse refractory setting, will continue to improve. And actually, we can work on optimizing the regimen, the FLAMSA regimen by itself. And this is a review from the Acute Leukemia Working Party, looking into the different FLAMSA-like regimens that, mainly used in different European countries, including, of course, Italy. And we performed a study published earlier this year, 1 month ago, I think, by Thomas Hennicke, about comparing all of these regimens. And you can appreciate that we had, of course, because of the wide variety of regimen, and you can see the number of patients is quite impressive, more than 2,000 patients. So we have some decent numbers. So we had to group them into groups, the TBI group, the chemotherapy group, melphalan, treosulfan, busulfan, the high-dose TBI plus melphalan, so quite aggressive, treosulfan, etc., clofarabine, etc. And because it is published and you can get access to the results, the major finding here is that if you have young and fit patient, no comorbidities, well, definitely, if you are able to deliver a myeloablative strong regimen like Flu-Mel and TBI 8 gray, well, you are around 40% leukemia-free survival at 2 years, relapse refractory patient. And if you look to the overall survival, obviously the results are also very good. If you consider the older patient, and I think Professor Olivieri also alluded, because of course the median age of AML at diagnosis is 67. So the majority of your patients are above age 67 or even 60. And here we took 55 as a cutoff. And actually, in this population with comorbidities, based on this large registry study, we found that the chemotherapy-based regimen, the Flamza chemo, the blue curves, are actually the one leading to the best leukemia-free survival or overall survival, because they are less toxic, but they also allow to some GVL effect. So I think the optimal choice of the conditioning regimen in the relapse refractory patient is important, and the key target is to have the lowest non-relapse mortality. I don't think we should really hammer the patient with chemotherapy to generate toxicity. We should rather avoid the toxicity. This is why in our multi-center prospective trial, we had 8% of transplant-related mortality at 1 year. The other approach is to work on maintenance therapy. And again, Professor Olivieri explained the rationale for this. When we trained, I think many of us in this room, I remember we've been told that allotransplant is like a sort of a single shot treatment. This is like you win or you lose. It's not anymore the case, because allotransplant for me and for all of us, I think, is a sort of an immunotherapy platform. So in this immunotherapy platform, you need everything before to prepare the ground. You need to optimize your platform, but also you need to give a post-transplant therapy. And this is what we call maintenance, or you can call it consolidation. There are many unknown questions. And Professor Olivieri mentioned, for instance, the recommendations from the Acute Leukemia Working Party published in April last year. So we were working very hard, even during the COVID pandemic, about the FLT3 ITD patient, because we know they have the very dismal outcome. And why we focus on this group? Because it's a good opportunity. We have many drugs now targeting FLT3 ITD, broad targeting like midostaurin and sorafenib, but you have also more focused targeting like gilteritinib, quizartinib. So it was very important to support the community with some guidelines. And our recommendation, based on expert and review of the literature, was clearly to deliver maintenance therapy after a transplant. And sorafenib can be a sort of a large option if you don't have a more specific, although it is not approved. And the good news, since we have published these recommendations, we have now 2 randomized trials showing that sorafenib can increase survival after transplant in FLT3 ITD. You have the publication in JCO from 3 or 4 months ago, but you have also another randomized trial from China in the Lancet Oncology, and that is the paper I alluded to in the editorial I have shown you, showing also in a randomized fashion that you can increase the overall survival, which is really very, very important. This is a FLT3 ITD, but of course, if the patient has no target, we're working on hypomethylating agent, but now we're combining them with venetoclax, because we believe that these patients, especially in the relapse refractory setting, especially if they have MRD positivity, and MRD is also another important parameter, they need some maintenance. So in conclusion, I hope that I have convinced you that, of course, we are all excited about the AML biology knowledge and the genetics of the disease and the help of the NGS. And of course, we are dissecting now the disease, and we have many small subsets, and we isolate the IDH1, the IDH2, and you have targeted drugs for this abnormality and this mutation. But at the end of the day, we have also to acknowledge that this is a very heterogeneous, complex, multi-step disease. And you will always, in my opinion, need the combination of treatment in order to succeed, especially if you are in the relapse refractory setting. So I think, and this is an important message to our colleagues working in non-transplant centers, because they see lots of these relapse refractory leukemia and they try to do a good job trying to give them the best available treatment. But these new drugs are usually quite expensive, that we should not neglect the option if they have a donor, and usually you have always a brother and sister or parents sitting around, you know, in the room when they come to the clinic. Well, we should consider the frontline allo because it is safe, it is feasible, and you can use these alternative donor. So with this, I'd like to thank you really for your attention, and you know my philosophy in life: never yield to the overwhelming might or strength of the enemy, and leukemia is our enemy. So thank you very much, and I'm more than happy to take a question. Thank you.
Thank you, Professor M.Mothy, for your really wonderful presentation that gives hope to a really high risk category of patients with AML. I congratulate with the results for CLO-based. I didn't know the last curve you presented. It is really very nice. And the presentation is open for questions.
A question is about prevention of GVHD. What do you think about the use of cyclophosphamide post-transplant, also in MAD transplant or as well as haploidentical transplant?
Yeah, no, thank you, Piero. Very, very important question. For the sake of time, I didn't go into the details, but of course, if you want to optimize the outcome overall, you have also to consider and think about GVHD. And you are absolutely right. Post-transplant cyclophosphamide is definitely, in my opinion, a revolution in haplo. But now we have strong data showing that it is also very powerful outside haplo in the mismatched unrelated setting. For instance, 9 out of 10, and one of our colleagues, Giorgia Battipaglia, who is now in Napoli, who trained for a few years with me here in Paris. I don't know if she's attending. Hello, Giorgia. She published that you can improve the outcome of the 9 of 10 unrelated donors with post-Cy, and you may have the same outcome. And actually, you have a similar prospective multi-center trial in press now. I can't say where, but it was a plenary session at ASH from CIBMTR showing that post-Cy in 9 out of 10. We have also data from the Acute Leukemia Working Party, the EBMT registry, showing that post-cyclophosphamide is a very powerful tool to GVHD prevention and can be safely used. For me, the question now is not about whether we should or we should not use post-transplant Cy. Post-transplant Cy really is a very strong universal GVHD prophylaxis. Now we are trying to improve post-Cy. So how can we improve? Because remember, the problem with post-Cy, it's high-dose cyclophosphamide. you have some toxicity, you have some cardiac toxicity, and we have published this, so you have to improve it. So we are working now on the dose. We have an ongoing trial with lower doses of cyclophosphamide. And hopefully, I'm quite optimistic that we can refine this. We are also working on improving post-Cy efficacy by adding a small dose of ATG. Because when you use PBSCs, because remember the initial experience with post-Cy is with bone marrow. But when you use PBSC, the incidence of extensive chronic GVHD or severe acute GVHD is higher. So can you use a small dose of ATG like thymoglobulin, for instance? And the answer is yes. And we have also data in favor. So the short answer to you, Piero, yes, post-Cy, we should go for it. I'm much enthusiastic about it. And we have also a prospective multi-center randomized trial, which will be the Van Beckum Award at the next EBMT meeting, national phase randomized trial, prospective trial, where we compare post-Cy to ATG in the related and unrelated setting. And I'm sure you will like the result during the plenary session of EBMT because we did the randomization.
Thank you very much.
A further question. Do you think that sorafenib could be helpful after transplantation in patients relapsing that have just tested second generation inhibitor for FLT3 like gilteritinib or crenolanib? Could it be possible it works even in these situations?
Yeah, very good question, Giuseppe. I don't know the answer because, of course, we don't have studies or big experience of patients who receive gilteritinib first and then sorafenib or quizartinib, because the problem is your gilteritinib, for instance, or quizartinib have been mainly used in the advanced relapse refractory setting. So really end stage. The only experience we have is with the patient who received, for instance, midostaurin as part of the induction, because this is the label, the approval, and it is widely used. And I can tell you, we can use safely and effectively sorafenib, even if you have received midostaurin as part of your induction or consolidation regimen. But I cannot answer for the sequence of gilteritinib, quizartinib, crenolanib versus, sorafenib. But I would personally think that whenever you have a mutation, just try whatever inhibitor you have in hand, because if you don't do anything, the patient will relapse. These patients, I think, we should not be naive. Of course, we believe in the power of the immune system, but we have to be realistic that you have to control the disease because the immune effect takes time. But also, don't forget, please, you have a paper in Nature Medicine by Robert Zeisser 3 or 4 years ago showing that sorafenib can also stimulate the NK cells and allows a secretion of IL-15. So you can stimulate the immune system. It's not abrogating the immune system.
I think you gave a lot of answers to my question, and I'm very happy with the answer, in particular because you had data after midostaurin. So this is really hope for these very poor patients. Okay, so any other questions?
We have no questions in the chat.
If not, maybe summarize when Mohammed is out, and we will, yes, represent some new questions later when you come back. And for now,
absolutely.
Thank you. And see you later.
See you later.
Okay. Now I am giving the word to Professor A.Nagler that will, yes, present something very interesting, that is the correct selection of patients and predictive scores. There are many now for transplantation outcome and more for organ toxicities. As we go on to elderly and elderly, this could be really very important. Thank you, Aaron.
To thank the organizers and especially Professor A.Olivieri for inviting me for this important meeting. And I will talk about selection of patient and predictive score for transplantation outcome and organ toxicities. I'm A.Nagler from Chaim Shiva Medical Center, Tel Ashomer, Israel, and I'm the Vice Chair of the Acute Leukemia Working Party of the ADLT. I have no relevant disclosures. So we know that allogeneic stem cell transplantation is an effective, potentially curative treatment for advanced high-risk hematological malignancies and AML. However, the procedures reduces relapse, but non-relapse mortality and morbidity might counterbalance this beneficial effect. And transplant-related risk factors, patient comorbidities and performance status, and disease-specific prognostic factor should help in the clinical decision whether to proceed to allogeneic stem cell transplantation or to apply non-transplant strategies. So if we talk today on the predictive score for allogeneic transplant in AML, we have the leukemia-based risk factor, which is of course cytogenetics, mutation, and these days measurable residual disease burden status at allogeneic transplant, and then the leukemia risk score as per Leukemia Net NPR, and recently very important, the DRI disease risk index. We have the host based risk factor, which are the age, performance status, and comorbidities, the SORO comorbidities. And we have the transplant risk factor, which is donor type, HLA matching, CMV status, graft source, conditioning, and GVHD prophylaxis, and all of these go into predictive score for allogeneic transplant in AML. So one of the first risk scores that were developed is the PAM, or pre-transplantation assessment of mortality. This was developed at Seattle based on 2,082 patients and was published back in Annals of Internal Medicine in 2006. And the parameter for this PAM score was the patient age, donor type, disease risk, conditioning regimen, the serum creatinine, the liver function test, ALT, pulmonary function test, FEV1, and the carbon monoxide diffusing capacity. And then we have the revised PAM, in which the serum creatinine, the ALT, and the carbon monoxide was omitted, and CMV seropositivity or negativity was added. Another important score is the post-remission score in AML, which the parameters are age, percentage of CD34 blast, FLT mutated versus wild type ratio, cytogenetic risk, and de novo versus secondary AML. This score was based on 586 patients. And for the 3-year overall survival, in the favorable post-remission score, we have 68%. For the intermediate group, it's 49%. And unfavorable group, it's only 20%. So in the favorable group, overall survival was the base with allogeneic transplantation, 82%, compared to 56% with chemotherapy and 66% with autologous transplant. And for the intermediate group, autologous transplant had the best survival probabilities, which was 62% versus 41% with chemotherapy and 44% with allogeneic transplantation. So the conclusion of this score is that the post-remission transplantation score may help to tailor treatment for patients with AML. Now, the most famous one is the disease risk index, which was developed by Harmad et al. And published in Blood 2012 from Harvard, in which the parameters are age, disease, stage of transplant, cytogenetics, and pre-transplantation ferritin. And this was developed in a group of patients that received reduced intensity allogeneic transplantation with fludarabine, carmustine, melphalan, and ATG. And so this was 100 patients. And the 2-year overall survival for the low intermediate risk group was 80%. And for the very high risk group was 66%. And the relapse rate, 2-year relapse rate for the low intermediate risk group was 9.9%. And for the very high risk group, it was 25%. And the 5-year overall survival was 56 for the low risk, 22 for the intermediate risk, and 5% for the high risk. And if we now look on the curve, so this is the overall survival according to this post-revision transplantation score, 76%. It's for the low intermediate is 80% in black, and for the very high risk is 66 in gray. And the leukemia-free survival for the low intermediate risk BRI score is 80%, and for the very high risk and high is 69%. And if you look on the relapse according to DRI is 14%, for the DRI high, very high is 25%, and for the low intermediate is 9.9%. And this is the relapse rate between related donor 26 and unrelated 11%. So maybe stronger GVL with the unrelated. So one of the other score, very famous, and one of the first score, if not the first one, published already in 98, is the EBMT score that was developed by Gratkold for CML patients. And the parameter for this course was the age, the disease stage, the time interval from diagnosis to transplant, the donor type, and the donor recipient sex. This was developed in CML patients, but then in cancer in 2009, Gratkold et al. Were able to show that this EBMT score is also predictive outcome in ALL, in AML, in MDS, in multiple myeloma, non-Hodgkin lymphoma, and aplastic anemia, as you can see here. And then, according to this Gratkold or EBMT risk score, which is again based on age of the patient, disease stage, time from diagnosis to transplant, matching, and gender combination, we have 7 scores or 7 group of patients that is very nicely separated. This is for the survival, and this is for the transplant-related mortality. We have also the modified EBMT score that was published in European Journal of Hematology based on 214 patients that was able to predict overall survival even better than the EBMT original risk score. And in the modified EBMT risk score, the time from diagnosis to transplant was omitted. And you can see here that the p-value for prediction of overall survival by the modified EBMT score is 0.0002, while in the original EBMT score is less sensitive of 0.003. And you can see here the curves. And this is by the modified EBMT score, the prediction of relapse nicely separated with a p-value of 0.049, and for the prediction of non-relapse mortality by the modified EBMT score of a p-value of 0.012. But there are also scores that are based on laboratory results, and ESSIX is the most famous and important of them. So ESSIX stands for endothelial activation and stress index, and the formulation is creatinine, double LDH, and divided in creatinine coupled on LDH and divided by thrombocyte count. And as you can see here, the training set validation set in adults, but also in children, it predicts the complication of transplant, so GVHD mortality, post-transplantation microangiopathy, and non-relapse mortality, but also predict overall survival, and it predicts better the overall survival in reduced intensity compared to the myeloablative, as you can see here, with the training in Heidelberg, validation in Seattle, and in Berlin. So for the comorbidities, we have the SORO comorbidity score. We all know here the parameter, a long list of parameters of cardiac and diabetes and obesity and blood pressure and peptic ulcer and pulmonary and so on. And if you have high comorbidity score, like equal or more than 3, you have very high non-relapse mortality compared to low comorbidity score, no comorbidity score. And then this is translated to mirror effect of survival. So with low comorbidity score, you have very good survival, while in high comorbidity score, you have very low survival. And actually and this was validated in the GITMO later on, both for myeloablative conditioning and reduced intensity conditioning. So you can see that the SOR comorbidity score predict non-relapse mortality, both in the myeloablative and reduced intensity, and also predict the overall survival in the mirror effect. So actually for comorbidities, we have the traditional performance status, comorbidity scores, and age, and there is some overlapping. So in most studies, the comorbidity score and the performance score are independent risk factors. In many studies, good correlation is with a high comorbidity score with age above 50 or 60, and the impact of some comorbidities may be age-related. So we, the Acute Leukemia Working Party, Dr. Jorgen Verselius and Professor M.Mothy developed this integrated score published in Leukemia in 2015, the EBMT score together with combining the EBMT score and the comorbidity score. And there was 3 groups of patients, or 3 levels, 0 to 3, which was low score, 4 to 6 point intermediate score, and above 7 high score. And you can see here the parameters that went into the score. And now if you look on the non-relapse mortality, it's very low for the low score of 0.0 till 3 points, of this being 8.8% versus a very higher in the high score of 0.7 to 9 with 38%. And for the overall survival, it's the opposite. So for the low score, 0 to 3 point, it's 69%. And for the higher score, 7 to 9, it's 43%. And so one of the projects now in the acute leukemia is to verify this score in ALL, because the basic Verselius score was in AML and with reduced intensity conditioning. So for the ALL, we have 1,345 patients. You can see that the EBMT score by himself don't predict so well non-relapse mortality, and the comorbidity score similarly don't predict so well the non-relapse mortality. But if you combine the score, like Verselius did for AML, you can see here a better discrimination between low, intermediate, and high acute leukemia score for prediction of non-relapse mortality. So then we went on and compared the various transplantation score or predictive score, the EBMT score, the pre-transplantation assessment of mortality, the revised pre-transplantation assessment of modality, the comorbidity score, the comorbidity score, and the E6 score. And you can see here the parameters that we're including in the score. So age was included in most of them, not in ESIX. Comorbidities in these 4 scores. But for instance, laboratory tests markers were included only in the ESIX. And you can see here the number of patients that each of the score was developed on. So the EBMT was developed based on more than 56,000 patients. the comorbidity H-score on 3,000, and you can see that some of the score, like the comorbidity score, was developed in 708 patients. You can see here the median age of the patient, the year of transplantation, and you can see that most of the score was developed in quite old transplant compared to these days, so the field have moved for more haploidentical transplant. So we need more efficient, maybe more new score, as you can see in a minute. The myeloablative versus reduced intensity conditioning in the various score, and the predicted AUC, and you can see that the prediction of the various score is between 0.62 to 0.69 or 0.76. So we went to the cohort of patients in Shiba Tel HaShomer, so more than 528 patients, and look on the various score how they predict transplantation outcome. So in this cohort of 528 Shiba patients, we had the median age was 55 up to 64. Most of the patients, 44% were with AML, about 10% with ALL. Most of the tumors were with intermediate score, 56, or high or very high score, 37%. The 74 were myeloablative conditioning, so 3/4 of the patient. And the match sibling was about 50%, 45% of the patient, and the rest was either match or mismatch unrelated. And you can see here the donor recipient CMV status. So here is the distribution of the individual scores across the population. So the median and number of patients per group stratum that are seen in this slide. And so in univariant analysis for the 2-year overall survival, non-relapse mortality, and relapse incident by scores, sorry for this busy slide, I will show you the graph in a minute, but you can see that not all the scores predict the same as for overall survival. So for instance, the comorbidity score is not predicting nicely overall survival, while the EBMT score predicted, the PAM score predicted even nicer, and as well as the revised PAM score. And so, and for the non-relapse mortality, the very nice prediction, for instance, the ESSIC score. So not all the scores predict the same, the various transplant parameters. And if we look on the graph for the various scores, 0, 1, 2, or 3 for the comorbidity score, or for comorbidity age, the 5 groups, and so on, one of the best score in the prediction is the revised pre-transplantation assessment of mortality, as you can see here. And even better, if you look now on discrimination over time, so the area under the curve, you see that the revised pre-transplantation assessment of mortality predict very nice, or the best, the overall survival and the relapse rate, but the ESSIC score here in yellow predict very nicely non-relapse mortality. And the score predicts better transplantation outcome here in red in the myeloablative compared to the reduced intensity conditioning. So the paper that was published in Blood Advance, the key point was the prognostic capacity varied across 8 allogeneic transplantation score, with the revised PAM showing modest benefit across several outcomes. And the ESSIC, a biomarker-based prediction model, is among the strongest predictive scores for non-relapse mortality. And overall, for the conclusion, the scores are better stratifying patients than provide individual prediction. That the performance varied based on the outcome that is measured, an effect observed most strikingly in the ESSIC score, which was predictive of non-relapse mortality, but not of relapse, for instance. And the revised PAM was roughly consistent in its prognostic capacity across all 3 outcome studies, and consistently had the highest performance. So then Soval et al. For our group developed a score, computerized score based on the data mining, computer intelligence, in which we gave to the computer 20 parameters that all clinicians in transplant know. So the type of the disease, the status of the disease, the Karnofsky score, the type of the donor, the year of transplant, the CMV status, the days from diagnosis to transplant, the age, and so on, and the conditioning, and the computers went through these various 20 parameters and calculate a score. And you can see that this acute leukemia machine learning score nicely correlate or predict day 100 mortality. You can see the straight line here. And we could separate nicely between, according to this data mining score, between 10 group of patients with the risk for overall survival. And this acute leukemia EBMT score was again verified in the GITMO cohort. So this is the overall survival, leukemia-free survival, and the non-relapse mortality. So we have here three interval scores. For low is less than 8.5 point, intermediate between 8.6 and 10, and high above 10. And you can see the nice prediction of the 2-year overall survival with a p-value of 0.001, 2-year leukemia-free survival between the various three scores, and non-relapse mortality. We also developed a predictive score for cord blood transplantation published in Clinical Cancer Research. You can see here the parameters that were included in cord blood transplant, the CMV status, the previous autograft, HLA matching, total cell dose, center experience, which is very important in cord blood transplant, use or not use of ATG, and the type of disease and the status of the disease. And you can see here this nicely separation of 6 groups and the p-value for predicting of overall survival and leukemia-free survival. And lately, we developed a score for autologous transplantation. And you can, this was published in 2019 based on the age, but for the first time by including mutation into autologous transplant for the leukemia risk. And you can see here that according to this score, it's not the observed, the predicted leukemia-free survival is very nicely correlated with the observed leukemia-free survival for 1 year, 3 years, and 5 years. So again, the disease risk index, this was developed by Armand and Harvard in North America, but was less popular in the EBMT. So we looked in a recent paper on the more than 100,000 transplants in the EBMT and look if the disease risk index also predict outcome in this EBMT data set. And you can see here the event-free survival and overall survival 2 years, and you can see it's nicely being predicted by the disease risk index. So the low disease risk index, the intermediate, the high, very nicely separated, with the low being the best overall survival and leukemia-free survival, and the very high being the worst. And so the change in the latest year in haploidentical in transplantation led to this looking on DRI on the three periods, and you can see especially for haploidentical transplant how the non-relapse mortality is reduced in haploidentical transplant from 59% to the 27% in the latest period. And this is translated to better overall survival. So the most striking for the difference for haploidentical transplant from 23% to 44%. And so because of this change in the transplantation field, we developed the disease risk stratification system on DRSS, in which we incorporated the mutation, de novo versus secondary AML, Philadelphia for ALL, cytogenetics, and divide the intermediate risk with Philadelphia and no Philadelphia, and we have five groups of patients: the low, intermediate 1, intermediate 2, high, and very high risk of patient. And again, this is on close to 50,000 transplants. And you can see here in a paper that is in press in Lancet Hematology, you can see yourself, for instance, for AML, the different overall survival in the novo AML or secondary AML. For the never AML, the difference in overall survival between CR1 and CR2, the difference by cytogenetic, but also by FLT3 for the first time. So this is DRI, but also including a new parameter, and this is by this DRSS. For the novo AML, again, CR2 now, the FLT3 is a major difference. The cytogenetic risk in secondary AML, so non-adverse cytogenetic risk and adverse, and the Philadelphia in ALL CR1. And these are the overall survival by the DRSS over the variation and validation cohort. So we had a temporal validation cohort, geographical validation cohort, extension validation cohort, and then the combination. And this is in the intermediate risk DRI stratified by the new score of DRSS. And now we also separate, because in the DRSS it was based for all leukemias, but this work also separately for ALL, predicting nicely low, intermediate, intermediate 2, high, and very high group, and also and for AML, of course. So if we move to organ toxicity, this is the usual cartoon of the various organ toxicity in transplantation, and when they appear early or late post-transplant, you can see here the VOD, the kidney injury, the pulmonary injury, and so on. So organ toxicity and the laboratory data also can predict overall survival. So for instance, you can see here in the paper published in BBMT in 2018 that albumin, if you have low or above 3.5, predict nicely overall survival, and also predict nicely non-relapse mortality, which is high if you have the albumin below 3.5, and it's much lower if you have above 3.5. And also kidney, very important, with the eGFR above and below 60. So if you have it below 60, overall survival is much lower, and the non-relapse mortality high. But if you add this laboratory parameter, for instance, albumin and eGFR, to the comorbidity score, then the area under the curve is our prediction value of the comorbidity is going much higher, as you can see here for overall, from the myeloablative conditioning and reduced intensity conditioning. So Joshua Fine and Ronnie Chauvel developed what they called acute severe organ toxicity, in which they took the most severe injury groups for the kidney and for the liver and combined them. And now you can see the percentage of what they call acute severe organ toxicity, which is the combination of severe renal toxicity and hepatic toxicity. And you can see that this acute severe organ toxicity varied in its percentage in any difference in the various conditioning for allogeneic transplant. But nevertheless, if you have this acute severe organ toxicity, it predicts short and long-term mortality. So for instance, if you have it for the overall survival, absent 76% here, but if it exists, it's only 22%. And for the 100-day mortality, you can see here also, if it presents, then in 30 days, then the overall survival is much lower than if it is absent. And the predictor for acute severe organ toxicity, the parameters that came out significant were the age, the disease risk, high disease risk, the EGFR for the kidney, and the AST for the liver. So if we look now on the cohort of SHIBA with the various conditioning and the various comorbidities, you can see here the prevalence of the various comorbidities, with the most prevalent mild hepatics and hypertension and obesity, then the pulmonary, less hypoalbuminemia, cardiac, and so on. And so if we look now on the comorbidity associated risk for non-relapse mortality, you can see again that the most predicting one is the serum albumin, less than 3.5, and the EGFR, which is less than 60. But you can also see that the predicting value here and significance is different in the various conditioning regimens. And so if we do the curve, so the cardiac comorbidity, if you have or don't have, is much more influence on the fludarabine busulfan than in other conditioning, as you can see in a minute. The infection, yes or no, is much more predictive and important in the fludarabine treosulfan, and the pulmonary is much more important in the fludarabine melphalan. So if we look now on with the similar idea, or this idea on the acute leukemia working party, 3,338 patients, cardiac comorbidities defined as the decrease in left ventricular ejection fraction or history of coronary artery disease, and pulmonary is the less than 65 for prediction of FEV1 or DLCO, and diabetes is the one that require treatment. You can see here the number on the cohort and the number of patients in the various conditioning. And so this is the disease status in the various conditionings that we compared and the age of the patient. So now if we look now on cardiac comorbidity, it's much more affecting overall survival in patients that receive fludarabine melphalan than in other regimen. And if we look on the curve, you can see that the difference, if you have these cardiac comorbidities in fludarabine busulfan, if you don't have it or have it, while in the fludarabine treosulfan, the cardiac has much less effect. If we look now on pulmonary, so it's much more influence in the fludarabine melphalan, predicting overall survival and non-relapse mortality. When you look on the curve, so fludarabine melphalan with the pulmonary, if you have pulmonary comorbidities, your overall survival is much lower than if you don't have it, much less effect influence on the predictive on the fludarabine with effects. And for the diabetes mellitus is more important for predicting affecting overall survival in fludarabine TBI. And if we look now on the graph, so fludarabine TBI, if you have diabetes mellitus or don't have it, and but in fludarabine busulfan, much less influence. So we concluded of this part. Individual comorbidities have regimen-specific association with overall mortality. So for cardiac, for instance, is more important than fludarabine busulfan. For the pulmonary, it's more important for the fludarabine melphalan. The association cannot be explained by the regimen intensity, and this suggests that individual conditioning agent may have properties which increase hazard among patients with particular comorbid disease. It will be nice if we will know this before transplant, and of course, we need confirmation of this intriguing data in other studies. And for summary for all of my talk about predictive score for allogeneic transplant and organ toxicity. So prognostic score should integrate disease, host, and transplant-related factor. The prognostic score should dictate clinical decision of allo versus non-allo strategy to our patient. The prognostic score should define the patient whom transplant-related non-relapse mortality and comorbidity might counterbalance the beneficial anti-leukemic. Leukemia-related parameters, mainly cytogenetic and molecular prognostic factors, are of vast importance. And one of the most important factors in transplantation outcome is comorbidities, which predicts transplant-related mortality and morbidity. Age and general medical condition, comorbidities, recipient immune competence, donor source, center's experience should be taken into account, and prediction of transplant-related toxicity and G.V.H.D. by prognostic score and genetic factors will hopefully result to reduced frequency and improving transplantation outcome. And last but not least, I would like to thank Dr. Shuvan, Ronnie, and Yeshua Fine. They did most of the studies and work that I, in RPI, on the studies that I presented, and was the basis for my talk. Professor Muhammad M.Mothy is the chair of the Acute Leukemia Working Party, and the chair where most of the studies were done, and Dr. Labopen that did a big part of the statistics. And thank you for the kind invitation. I will be happy to answer questions.
Thank you. Thank you, Professor Nagler. These are very important data because from a practical point of view, they could be really helpful to hematologists and transplantologists. In particular, comorbidities analyzed with the data you gave us. Maybe they need some confirmation, but they are very important, and you gave us some guess about which could be the best conditioning for the single patient or the single category of patients. As well, I see that the scores are going to be refined and refined, but the last ones are so interesting. That is the DSS score for all the pathologies. It is really intriguing. Any questions?
There are
well, waiting for questions, I would like to ask the picture showing the risk from, I would say, yes, CLL-CR coming to AML, very high risk. Did you go on with this kind of study, applying this model to other out of AML?
Sorry, but I could not hear the question. Can you repeat?
Yes, I was intrigued by the slide where you showed the increasing risk with DSS system, scoring system, from CLL, CR, and going down to AML high risk. So a system that could be applied to all diseases based on a scoring system. Did you apply this system to other diseases out of AML, or it is still an early study?
So thank you for this important question. Of course, this was just the first study, which is actually online, appeared last week in Lancet Hematology. And now the plan that we are going for each disease to calculate the DRSS. So we don't have this data for CLL. We're just beginning now in the separation of AML and ALL, but the plan is to do it if we will have the enough number to other the specific diseases as you suggested as well.
Thank you. It will be very interesting to see these results for everybody.
Yeah, I fully agree. Thank you.
Any other question? Maybe
Can I ask a question to Professor Nagler? Arnon, can you hear me?
Yes, I hear you. Yes, thank you.
Congratulations for wonderful presentation. And keeping in mind that today about 1/3 of allogeneic transplantations have been performed by using the post-transplant cyclophosphamide platform. Do you think we need to adjust the score of for prediction of mortality for this specific kind of conditioning?
Yes, I fully agree with you, because the post-transplant cyclo changed the biology of transplant. We have the VAGO data that you presented in your introduction, Fabio Ciceri, together with the Baltimore group, showing that the NK, donor NK activity is lost during the first month post-transplant, the recipient NK activity, till the donor NK activity is coming after 1 month, and we have the upregulation of T regulatory cells. And this is obviously affect both the GVHD, but also the graft versus leukemia effect. And we just submitted now an abstract to EHA about yes or no role for MRD in sibling and unrelated transplantation receiving post-transplant cyclo, with the same idea that the post-transplant cyclo will maybe change the interplay between GVL and GVH. So I fully agree that some of this risk score, for sure, or I can predict, will be influenced by post-transplant cyclo, and we may need to revisit that issue again when we have enough numbers of unrelated and sibling transplant with post-transplant cyclo, because in the haplo, anyway, about 85% of the haplo in Europe are now with post-transplant cyclo. So all recent data with haplo-identical transplants are with post-transplant cyclo, but the number in unrelated and siblings are still lower.
Thank you.
Okay, if there are no other questions, thank you, Professor Nagler. And now Giovanni Martinelli will show us the role of new drugs before and after SCT. Thank you, Giovanni.
Thanks to you, and thanks to the organizer. Particularly, I would like to thank my great friend for the nice presentation, Olivieri, Professor Olivieri, because this is a great occasion to stay together and to present the data. I don't know if you are able to see my presentation. I suppose to be able to share now. Let me understand if you are able to see my video.
Yes, you have to put the full screen. Okay, now it's perfect.
Thanks a lot. So I will start immediately with some of the drugs that in this moment are very exciting, because we finally have, after a long desertic transition with nothing else than 3+7 chemotherapy, two very important new era of new agent. Particularly, I would like to thank the organizer to give me the opportunity to speak about the CPX351. I was involved to the development of CPX351 from the Atlanta ASH meeting in 2008. It was at that time a small company developing the drugs, and it was clear. I remember it was a reviewer of the Blood journal, which was presenting the first data in a blastic phase of chronic myeloid leukemia and acute myeloid leukemia refractory resistant. Now we get more data, and finally the registration of the drug was approved also in Italy, in Europe, for reimbursement. So this is a drug that is now available. And I will try to present the data in older patients with newly diagnosed high-risk secondary acute myeloid leukemia and outcome by age subgroup and among responder, which has been presented by Jeffrey Lancet and published. Just to remember that this drug is a very innovative drug in which it was a dual drugs liposomal encapsulation of daunorubicin and cytarabine in a synergistic 1:5 molar ratio. It was approved in the United States and EMA for the treatment of adults with newly diagnosed therapy-related acute myeloid leukemia or acute myeloid leukemia MRC. And the primary endpoint analysis of the pivotal phase 3 study evaluated safety and efficacy in older adults with newly diagnosed acute high-risk secondary acute myeloid leukemia. And this, in my presentation, I will demonstrate that CPX significantly improved median overall survival primary endpoint versus conventional 3+7 with a strong support, scientific support for CPX, and the safety profile was good. I would like just to remember the randomized study, which was previously untreated high-risk secondary acute myeloid leukemia, elderly, 60-75 years of age, able to tolerate intensive chemotherapy with a performance status 0 to 2. Stratification was to CPX 351 with 7+3. In these 3 groups of patients, very bad prognosis, therapy-related acute myeloid leukemia, acute myeloid leukemia with history of MDS, or acute myeloid leukemia with history of myelomonocytic leukemia, de novo acute myeloid leukemia with bad karyotype, 60-69 years of age, 70-75 years of age, 2 cycles of induction, evaluation for patients getting CR, CRI, a consolidation 1-2 cycle, and then evaluation of that, follow-up, overall response of 5 years, response of 5 years. And this was doable, but CPX in induction 100 units per square meter on day 1, 3, and 5. This is the schedule. Day 1 and 3 of second induction. Consolidation 65 units. Clear that the CPX was superior. You see that from the beginning, from the first 3 months, you get at least 21% free a Kaplan-Meier estimated survival rate versus only 9% of population, 18% Kaplan-Meier estimated survival rates versus 8% with conventional chemotherapy, with a median overall survival which was double, 9 months versus 5 months with conventional chemotherapy. And this was confirmed and strongly suggested of an activity, important activity of CPX, when we observed the overall survival landmark from the data of allogeneic bone marrow transplantation. 7+3 was able to give 10.25 median overall survival months not reached at the time of the analysis with CPX, confirming the initial observation of strong survival advantage for patients treated with CPX. So there was a 57% 3 years overall survival versus 23%, and a 5 years was a 52 versus not estimable in the patients treated with CPX. So the first conclusion was the drug was good, was superior by the conventional chemotherapy, prolonged overall survival in majority of patients, and data support the ability to produce and contribute to long-term remission survival in very bad population with high risk secondary leukemia and very bad MDS-related karyotyping. Then it comes the data of the allogeneic bone marrow transplantation in patients enrolled in the protocol 301, which was a randomized phase 3 study that I presented in older with newly diagnosed high risk, and I repeat, secondary acute myeloid leukemia. Remission rates was superior 48% in 309 randomized patients, more than the other receive CR, CRI, so you get 48% response versus only 33%. It was clear that also majority of the patients were allowed to get proceed to allogeneic bone marrow transplantation, including more patients who proceeded to hematopoietic stem cell transplantation in remission with CPX-free 51, and these are the data: 35 versus 25, 56 in CR versus 46 with 7+3. So this was the baseline characteristic of population, no difference between the two populations, and the landmark analysis data from the data of allogeneic bone marrow transplantation, as I mentioned, was superior in the majority of the patient. And if we analyze the patient getting CR, CRI, and then following by an allogeneic bone marrow transplantation, there was not reached median overall survival versus 11.65, and 58 of this population had a 3-year survival, 52 at 5 years. So we can probably suppose that this population was cured in the majority of the cases, suggesting that CPX has a strong anti-leukemic activity, but particularly had a strong pre-initiating leukemia stem cell activity. The cumulative incidence of relapse was in favor for CPX, getting less amounts of population relapsed after allogeneic bone marrow transplantation, and more importantly, very strongly difference between the cumulative incidence of non-relapse mortality, which means that we don't reduce just the recurrence of leukemia, but we were able also to reduce the toxicity associated with allogeneic bone marrow transplantation in this very poor population. So the conclusion was the analysis of allogeneic bone marrow transplantation outcome in patient enrolling in this phase 3 study, showing a strong activity of CPX in older adults with high risk and secondary acute myeloid leukemia, resulting in more patients bridged to allogeneic, more patients in CR/CRI compared with an improved overall survival. And this opened the strategy to use CPX in a post-remission strategy, which it is absolutely important after allogeneic bone marrow transplantation. And I would like to move on in my second part of my presentation to how we can now get in other drugs in combination with CPX, since we are now getting new drugs in acute myeloid leukemia, which has been registered. And this has been done in a very clever protocol. Unfortunately, I was unable to be part of this protocol. I was absolutely curious to be part of this strategy, which was called VFAST, phase 1B master trial to investigate CPX combined with various target agents in patients with previously untreated acute myeloid leukemia, which has been presented recently by Tara Lean and the group of Mark Lewis. I would like to remember that it was a scientific rationale to combining CPX with other agents. The first agent was venetoclax in RA. Venetoclax is a strong BCL2 inhibitor, now registered for acute myeloid leukemia in first and second line. The other drug was midostaurin, a FLT3 inhibitor, which is registered for FLT3 population, and azacitidine, which is a strong mutant EDH2 inhibitor, which targets also variants in acute myeloid leukemia associated with EDH mutation. And this was a strong preclinical rationale in the majority of the patients. Just to move quickly to the data, I would like to present the study design, which was eligible patients with previously untreated acute myeloid leukemia who are fit for intensive chemotherapy, getting cytogenetic and molecular status, and then getting harm assignment with FLT3 wild type EDH2. CPX was associated with venetoclax. If there are FLT3 internal tandem duplication or mutation, CPX was associated with the midostaurin. Personally, I believe that midostaurin is a good drug, but I prefer gilteritinib in the majority of the cases, and harm EDH mutation, CPX 351 plus in azacitidine EDH2 inhibitors. And additional harm may be added in the future. This is a dose escalation phase 1 with the aim to to understand the toxicity and the safety of the combination in a population with acute myeloid leukemia between 18 to 75 years old, newly diagnosed, eco performance status good, following laboratories value, and excluded was acute promyelocytic leukemia, favorable risk, active leukemia at the nervous system, and other minor points of exclusion criteria. And the dosage schedule was very interesting also. Let me understood in presenting together that CPX was in combination in so-called induction 1. Then if the patient doesn't reach a CR, can be underscore to induction 2 based on interim analysis of bone marrow finding with CPX combination. If the patient obtains CR, CRA, or CRH, can move directly to consolidation, achieving the different combination of the drugs, and then follow up for overall survival for 2 years. In the arm A, as I mentioned, there was a FLT3 wild type, CPX was 100, venetoclax was 400, day 1 and 14. In this induction, if the patient were FLT3 positive, midostaurin was 50 milligrams and 100 CPX. If there was EDH mutation, 100 CPX and azacitidine 100 milligrams. In the consolidation was CPX were reduced to 65 units square meter. You see here in all the arms 65, not 100, but 65 units square meter. Then venetoclax was maintaining, midostaurin was maintaining, and azacitidine was maintaining. Primary endpoints was safety and tolerability. I just presented the data of one which has been presented as abstract at the ASH meeting this year by my friends Kadia and Ago Kantarjan from the MD Anderson Cancer Center Experience, in which they presented the results of the phase 2 study, CPX plus venetoclax in patients with acute myeloid leukemia. You see, the population was possible to be treated with previously exposed to venetoclax and resistant or de novo to venetoclax. And you see that the population that has been treated getting a strong effect if there was no prior exposure to venetoclax. If there was prior exposure to venetoclax, the results are a bit less exciting. And the conclusion was that the safety profile of this combination is important and can be moved on in the phase 3 or additional combination. This was also confirmed by a leading phase, which was at the dose level -1, 3 or 6 patients going down in the dose level, since there was a strong toxicity in some of these patient combination. This is also an experience that we are doing daily. I'm doing daily in Italy. The experience that 400 milligrams of venetoclax probably is too much for the majority of the patient, whatever is the combination, whatever is the association. I would like to show two slides in order to understand how we can probably have to reconsidering venetoclax dosing when we combine with CPX or other drugs. And this was 44 induction, 29 consolidation. The venetoclax was reduced to 50 milligrams, 150 and 300 milligrams if there are no CPX inhibitor associated, which means in the majority of the case, the azoles antifungal therapy with CPX in the majority of the patient, the doses, as I mentioned before. And you see that what's happening in the majority of the patient, even if we use the run-up system, 400 milligrams will be associated with a toxicity, with a prolonged toxicity, and hypocellular or acellular for a prolonged times, with a prolonged myelosuppression in the majority of the case, which is not associated to CPX, but is associated with venetoclax. We know that venetoclax was developed for CLL, but when we use venetoclax to the acute myeloid leukemia, we encountered every time in a prolonged myelosuppression, particularly the second cycle of venetoclax, second exposure to venetoclax or prolonged exposure. I discussed it with Cantargian several times at this point, and he agreed with us, and Ravandi agreed with us that we have to reduce the dosage of venetoclax, particularly the second cycle, which was in the majority of the cases reduced to day 2 and day 8 only, with a reduced exposure of the venetoclax. You can see here venetoclax only day 2, day 8, few days of venetoclax dosing. And let me say this was probably associated with 50 or 100 milligrams, avoiding in the majority of the case the use of 150 and 200. Personally, I believe that also with venetoclax and ASA, this dosage prolonged for more than 8 days are probably toxic for the majority of the patient. And this was associated with the experience also with the CPX plus venetoclax. You see here the median age, the parameter, majority of the patient was unfavorable, but not all the patients are unfavorable. And you see also that most of the patients getting P53 mutation, we know that the P53 mutation and DNA methyltransferase and RAS mutation are associated with very bad prognosis. So this is a very dramatic mutation asset in the majority of the patient. And we also encounter in this experience that CR, CRI were associated with a percentage not extremely exciting. Overall response was 44, and we get patients who died in 4 weeks, 10%, and died in 8 weeks, 20%, with a majority of the patients who be able to get only one cycle in the majority of the cases. That was associated with infection. You see here grade 3, grade 4 was infection, thrombocytopenia, neutropenia, and let me say an bone marrow failure, which has a prolonged more than 2 months times of aplasia. And this is a experience that we are also encountering in GMEMA clinical trial with the WuFly, where the first cycle in a very elderly and very bad population associated with the conventional chemotherapy fludarabine-based regimen was associated with a strong amount of patients obtaining CR, but a prolonged aplasia in the second cycle of WuFly experience. So we have, you see here that the overall survival, there is even if the number of patients are few, getting died in 9 patients, the majority of these patients has a prolonged cytopenia, then infection, and they died in CR. Most of the patients died in CR. In the relapse-free survival was constantly good, which means that the drugs and the combination is extremely effective at the leukemia stem cell level. And this is overall response by response, cumulative proportion survival with the complete versus censored, the non-responder. So few patients, but the data are very, very promising in this bad population. Let me conclude my presentation with this cartoon that I like. Why we are doing a different strategy in acute myeloid leukemia. Now we get these new drugs. We know that today this is the leukemic stem cells, this is the extracellular, and this is the virus or the fungal situation. We know that the majority of this population use the novel pathway for produce nucleoside. Nucleosides are essential for acute lymphoblastic and acute myeloblastic leukemia stem cells. And the leukemia stem cell use the novel pathway to produce AMP, UTP, GTP, ATP in general to produce nucleoside. If it is not able to produce that because we block the novel pathway, the leukemia stem cell use a savage pathway with an internalization of nucleosides from the bone marrow, the microenvironment, with this receptor. We know that is a chained end receptor. And the leukemia stem cell has a very important UMP synthesis in the majority. So you use glucose since there is not too much oxygen in the niche osteogenic needs, use the glucose not to produce energy, but to produce a pentoso phosphate pathway nucleoside. If we block this pathway with an oncogene addicted gilteritin or CPX351 or conventional chemotherapy, and we block with ASA or with venetoclax this pathway, we block the de novo synthesis of nucleosides. So the cell rescue and survive because they are able to use the salvage pathway. So they are totally dependent from the external nucleoside. But if we block the nucleosides import from CHENT and ENT receptor, I use fludarabine, but there are other drugs that works at this level. We totally blocks the nucleosides selectively at the level of the leukemia stem cell. And this is probably the leukemia stem cell nucleoside neosynthesis and acquisition related to microenvironment and also parasite or fungal, which are also dependent from the external nucleoside to be able to get in a life. So leukemia stem cells are extremely sensitive to depletion of de novo nucleosides and salvage therapy nucleosides, opening the opportunity to eradicate the majority of the leukemia, independent from the karyotype. So in my conclusion, prolonged myelosuppression was dose limiting when combining standard dose with CPX with 21 days of venetoclax. 21 days are probably too much. 8 and 10 days could be sufficiently. Low level of venetoclax has to be used, 50, 100 milligram. And in the high risk population, we can obtain a very high rate of CR since the combination is very active at the leukemia stem cell. And we probably have to understood better how to combine this drug in the majority of the patients. And I would like to thank for your attention and opening for discussion. I suppose there are some very interesting issues that can be discussed together. And thanks again with my friend A.Olivieri for this kind of invitation that I take with care.
Thank you, Giovanni, for your nice presentation. And I really liked the fascinating cartoon with nucleosides that gives us even more hope. It is really nice to see where you can stop the food for leukemia cell. I don't know if it is completely true, but it is so fascinating that I try to absorb it. Saying after this, I would say that really CPX and venetoclax are getting ground and ground in the therapy of patients that are really sometimes in terrible condition or elderly or very elderly. So we really are now not facing quite really frail patients. There is no frail patient for venetoclax, but more you have really CPX that added with venetoclax and other drugs could give us so nice results, even if some are still so early, as Giovanni said. Have you a comment, Giovanni? Are we waiting for questions now?
My comment is you are totally right. We probably have to change our mind. In GMEMA, we do have an amendment in which we do only induction. You know, from 30 years that the induction is not sufficiently to eradicate the leukemia. And after induction, we have to do consolidation and then a second consolidation and then allogeneic bone marrow transplantation. In a 28 population, de novo of the GMEMA protocol, we decided to don't use, if you use venetoclax, fludarabine and RHE, but it could be the same with the CPX, you can use just one cycle of induction and then move directly to allogeneic bone marrow transplantation, which is probably a change of strategy. Since now the allogeneic bone marrow transplantation could be done also in elderly population, it could be possible to do one cycle, venetoclax plus CPX, short exposure, 10 days of venetoclax, low dosage of venetoclax, 50, 100 milligrams of venetoclax, and then moving quickly to allogeneic bone marrow research and procedures. That will be probably a new strategy of cure acute myeloid leukemia. I don't know if it works. It looks like to work for now, but it could be very interesting to understand if we really have to change our paradigm of induction, consolidation, and allogeneic bone marrow transplantation to a new one, which is induction and then transplantation.
Yes, is really fantastic just to have a new scenario in an area where, as Mohammed said before, we had 40 years without no scenario.
Giovanni, ciao. What do you think to adding venetoclax to classic induction treatment 3+7 in young patient with standard risk AML?
Personally, I believe that we can lose a bit of the advantage of CPX. CPX has two advantages. The first is liposomal formulation, makes possible the majority of the delivery of the drugs at the bone marrow level, which is a great advantage. We avoid the extramedullary toxicity. And then coming back to the conventional chemotherapy plus CPX could be probably a step back, not a step forward. The second one is why we have to use conventional chemotherapy. Now we have the new drugs entering with a strong leukemia stem cell efficacy, because venetoclax add something more at the leukemia stem cell, and CPX adding something more at the leukemia stem cell, because it works on the edge of the osteoblastic niche, which is the more difficult to be touched by conventional chemotherapy. So I'm not too much in favor to go back to the conventional chemotherapy. You know, I like to go in the future, and sometimes there are no drugs until now to move in the future. But it could be something that we have to use with more attention and more research.
So, in your opinion, CPX will substitute 3+7?
Yes, and will substitute, and will be probably also an important advantage in the majority of the patients. Could be.
Thank you.
I have time for a short question to Giovanni. Giovanni, can you hear me?
Yes, perfectly.
Oh, congratulations, Giovanni, as usual. A wonderful lecture. Considering the increasing number of patients treated with CPX, it's a common observation that these patients have a very long and incomplete, often hematological recovery. I think, I don't know, I would like to have your opinion. It's not the case to reconsider the definition of hematological response and the tools of evaluation, because many of these patients have an incomplete platelet recovery or hypercellular bone marrow after treatment.
This is a very important question. I have recently several clinical trials that they define not CR, not CRH or CRI, but non-evidence of leukemia. Non-evidence of leukemia is something that means you remove the clones, the leukemic clones, but we don't have a normal hematopoiesis still recovering. And this is particularly in elderly and myelodysplasia or myeloproliferative or patient moving to the transformation from a myelofibrosis. I totally agree with you that I'm doing a lot of study in this moment with NGS. I do NGS every time after venetoclax treatment when the patients are not recovered, in order to understand if there is a myelodysplasia clones which can be recognized by molecular 2%, 3% mutation load, which are probably the pre-leukemia phase that we probably lost in majority of the patients. There is a pre-leukemic phase that we lost. We cure leukemia and we recover not completely, but to MDS. That will be an opportunity. I have a patient, if I have 1 minute more, I have a patient with the EDH mutation, an elderly patient. I treated with the ivosidenib. He became remission of leukemia, but still myelodysplasia with 5q hematopoiesis, 5q deletion hematopoiesis. I treated with the lenalidomide, and the patient come back to complete remission. So it's possible that the multi-step cancerogenesis can be reported back again to the normal hematopoiesis. Of course, allogeneic bone marrow transplantation is the best way to do that.
So I totally agree, because this is a critical point in order to proceed or not to proceed to allogeneic transplantation.
If you get mutation which conference clonal hematopoiesis, strong clonal hematopoiesis, you have to consider the allogeneic bone marrow transplantation as the unique way to recover in normal hematopoiesis. However, the patient stay in transfusion dependency for months and months, and even if infected, but transfusion dependency was a prolonged side effect of venetoclax treatment of the majority of the patients.
Indeed, I fully agree with you. Thank you.
Thanks to invitation.
Okay, thank you, Giovanni. Now I leave the chair to Piero Galieni for the following part. Thank you.
So good afternoon, everyone, and thanks to Professor Olivieri for the kind invitation to participate in this meeting. And we are approaching the conclusion of the meeting with the presentation of 2 clinical cases that lead us to real life. The first one will be presented by Dr. Claudio Cerchione of the Istituto Scientifico per la Cura dei Tumori di Meldola, and concerning a transplant in a fit patient with AML. And the second one will be presented by Dr. Francesco Saraceni from the Cattedra di Ematologia dell'Università di Ancona, who will present a case of transplantation in a frail patient with AML. And so please, Dr. Claudio, to present your case.
Thank you, Professor Galieni, and I want to thank Professor Olivieri for this great invitation. I'm honored and it's a pleasure for me to be here in a so big expertise community, a so big event about AML. And our idea was to share the present knowledge about the real life scenario in acute myeloid leukemia, secondary acute myeloid leukemia. That's why we divided the presentation in 2 parts. I will start with a background about the main clinical trial, retrospective clinical trial in real life scenario, and then Francesco will continue with some new experience. Professor Martinelli has brilliantly presented the phase 3 registrative trial of this new opportunity we have currently in acute myeloid leukemia, and I wanted only to show again the current status of the data, which has been confirmed in successful analysis, which has recently been presented to the main international events. It focused on older patients aged 60-75 in secondary therapy-related AML with history of chronic myelomonocytic leukemia, history of myelodysplastic syndrome, or de novo AML with MDS karyotype. They were all previously untreated and able to tolerate intensive therapy. This was the phase 3 design of the study, in which CPX was compared with the conventional chemotherapy as an induction, a subsequent induction, and consolidation 1-2 cycles. The primary endpoint was overall survival, and that's why it was really interested to evaluate the collection of data from two big countries, the eternal comparison between Italy and the French, which has been confirmed also from Vixeos real-world studies. And I start from our country, from Italy. Was objective of this great paper published from Guolo and the group of Professor Lemoli and many institutions from Italy was to evaluate the therapeutic role of CPX-351 in a real-life setting, in particular for evaluating the outcome of a patient who received hematopoietic stem cell transplantation in first complete remission. The key methods was a retrospective collection of data from patients treated by this molecule. They were collected by 31 institutions, hematology institutions from our country, and the endpoint was to evaluate the overall response rate defined by complete response and the complete response with incomplete count recovery, and overall survival, which was calculated from date of AML diagnosis to date of death or last time that the patient was seen. The study population was included between Jan 2018 and July 2019. They collected 71 patients. They were data arising from Italian compassionate use program, so the pre-commercial phase, with a median follow-up of 11 months. The study design was an induction course with Vixeos at standard dose, repeated on day 1, 3, and 5, a second induction. Sorry, because I don't see very good the slide. A second induction with the same dose on day 1, 3 was allowed for patients failed to achieve at least a complete response with incomplete recovery count after the first induction cycles. Up to 2 consolidation courses with Vixeos were permitted, and allogeneic stem cell transplantation consolidation was allowed in every phase of the treatment. This was the baseline characteristics of the patients, which was not so much different from the registration trial, with a median age of 65 years, a range between 52 and 79, about equally divided between male and female. And the AML categories, secondary AML categories, were equally distributed with a little bit more MDS and CMML AML post these two categories. Relevant comorbidities were present in about 90% of patients, as we know from our population over 70. And these were the molecular baseline characteristics of patients, which were evaluated according to European Leukemia Net 2017 criteria, in which we can see that more than half, 55% of patients were high risk. And moreover, they collected the molecular evaluation. We have 7% of NPM patients, the same number of FLT3-ETD patients, and TP53 was expressed in 35% of the patient. And this is another important data that we can see deeply in the results. This was the history. I really appreciate this flow in which we can see that there were 78 patients enrolled in this compassionate use program from 38 Italian centers. And then we can see how many of them proceeded directly to allogenic, 2 that proceeded after a second induction, and so on. This was the complete history of this study, this retrospective evaluation. And I want to focus about the overall response rate, which was 70%, with the other 8% who achieved a partial response. Only 20% did not respond at all from Vixeos treatment, and the treatment-related mortality was only of 7%. Moreover, the authors evaluated MFC-based MRD assessment, which was 37%, but also WT1-based MRD assessment, which was about 54%. These were data about overall survival at 12 months, which was about 70%. And in particular, they divided the patient into favorable versus intermediate cytogenetic risk, poor cytogenetic risk, and the previous treatment, and also with the molecular evaluation. Median overall survival was not reached at 12 months. And we can see also the incidence of relapse, in which we can see that the patient in first complete response receiving allogeneic stem cell transplantation is difficult that relapse in the first year, but there is a big difference, a statistical difference between the patients who were not able to receive allogeneic stem cell transplantation, and this confirmed the data of the registration trial about the transplantation, which positively correlate with the incidence, with the not incidence of relapse, in particular in the first year. Safety profile also confirmed the data we had from official trial. In particular, 80% experienced more than grade 1 extrematological adverse events with the FUO, sepsis, pneumonia, and mucositis. Median time to absolute neutrophilic count recovery was 38, and this is confirmed also from our clinical real-life evaluation. Usually this is a problem. There is a difficult recovery from neutrophilic count, maybe a little bit different from the other induction profile, but without positive correlation with the more adverse events. And moreover, median time to platelet recovery was 28, with a range between 12 and 60. About the rate of mortality was 30%, 5 deaths due to TRM, and 16 deaths were due to refractory disease. So I think this is also an impressive result if we consider the subset of patients, and we consider that these patients until some years ago had no focused opportunities in the treatment. So concluding this first part with the Italian compassionate use program in a real-life setting, this is an effective regimen for high-risk AML patients, which represents a remarkable improvement in the treatment of them and may improve the results also of stem cell transplantation, inducing a good quality remission with acceptable toxicity and increases results of transplantation through a reduction of TRM and post-transplant relapse rate. Moreover, the lower incidence of severe complication may reasonably increase the number of elderly patients which can be evaluated to undergo to intensive induction and consolidation for allogenic stem cell transplantation. Notably, CR probability was not affected by any of the most relevant prognostic factors, such as ALN stratification risk and unfavorable cytogenetics. And maybe this confirms that we should also reevaluate the way which we consider the risk, we evaluate the risk of AML patients in era of novel agents and of big sales in real life. And moreover, the presence of TP53 mutation in the context of a complex karyotype did not impact of complete response rate. In particular, complete response rate was 75 in patient showing TP53 mutation versus 77% in patient with the TP53 wild type. This was a data which I had no time to show, but is really important to consider, because we know how much is difficult in our current clinical practice to treat this kind of a patient. Switching to France compassionate use program, the objective was the same, was to analyze the efficacy and safety of this molecule in real life setting, evaluating the impact of mutation on response and of MRD in responders. And the key methods was a retrospective evaluation of data from 12 centers in France, whose objectives were overall response rate, the endpoint, and then the other was the overall survival, calculating in the same way from diagnosis to date of death or last follow-up. Study population was included between April 2018 and November 2019, 103 patients, all more than 18 and with a newly diagnosed secondary AML. Information about NGS on more than 19 genes was performed in more than 70% of patients. This is another important data. Among responders, 46% had MRD evaluation assessed not only by NGS but also by flow cytometry and RT RT-PCR in patients with documented genetic alterations such as NPM and also gene overexpression WT1. These were the patient characteristic. Also in this case, we have a perfect comparison with the registration trial with a median age of 67, and equally distributed in male and female, and also a correspondence with the AML subtypes with the registrative trial. Genetic risk showed adverse genetic ALN risk in more than half, in this case 61%. And this was the baseline NGS evaluation performed, as I was saying before, in 74 patients. 98 patients received 1 induction cycles, 5 received 2 induction cycles. Response rate was 59%. 61 patients had the response, in particular 55 with a complete response, 4% with an incomplete recovery count, and 3 patients with a partial response. Only 1 patient needed 2 induction cycles to achieve complete response. MRD evaluation was performed at the end of the induction, and there was an MRD negativity, which in my opinion is an impressive data if we consider that this is not a regular trial, and there is an selection of the patient, and is a particularly severe setting of AML patients. Poor prognostic factor for ORR in univariate analysis seemed to be prior treatment with hypomethylating agents, the presence of a monosomal karyotype of TP53 mutation on DV1 mutation of PTPN1 mutation, which were confirmed the TP53 and PTPN1 mutation also in multivariate analysis. These were the overall survival curves, in particular with a median follow-up of about 9 months. Median overall survival was 16 months, and of 36 out of 103 patients who underwent transplantation were 35, and moreover, median overall survival also in this case was not reached in transplant patients versus 9 months in non-transplanted patients. This was overall survival according to European Leukemia Net risk stratification. Also in this case, there was a confirmation that this is not able to predict a significant difference in overall survival, as we can see from these curves. And about safety, early date rates were 6% and 8% at day 30 and 60 respectively. 24% relapsed with a median time to relapse of 5 months. About the 36 transplanted patients, 5 relapsed compared with 19 non-transplanted patients who underwent to a relapse. Median time to neutrophilic count and platelet recovery after the first induction were 29 days and 28 days respectively. Concluding about the French experience, the observation confirms efficacy and safety of this new opportunity in poor risk AML in real life French setting, in high rate CR with low MRD compares favorably with the previous report using 7+3 in elderly and favorable AML, and may explain the favorable outcome observed in patients after allogenic stem cell transplantation. Of the responders who were evaluable, about 60% attained MRD negativity. CPX overcomes the poor prognosis associated with unfavorable mutation defined in ELN risk stratification. And this French court moreover show interesting response rate in unfavorable mutations, including a TP53 population, which provide further evidence and are really interesting in context of the study 301 post-hoc analysis result. In conclusion, focusing on both the real-life experience, we know that this is the first chemotherapy to significantly increase overall survival versus conventional chemotherapy for patients with high-risk secondary AML. It may improve transplant outcomes for patients with versus conventional chemotherapy. Moreover, it permits to achieve a significantly greater response, including in TP53 population, and moreover, in patients with a complete response, it correlates positively with the longer median overall survival. benefit is greater if used for both induction and consolidation. There is a great need to collect all Italian patients, I imagine, into a real-life registry with this molecule. And the near future, new challenges are to collect particular cases, which can teach, as we are seeing, how to improve the use of this drug. And I think that is great to start from the Ancona experience, with Francesco will now show after my presentation. I want to thank Professor Martinelli, which is my scientific director, the hematology division, which is aided by Gerardo Musuraca, and the division of Cesena, our parallel site, which is also related to IRST, and you for the great attention.
Okay, thank you, Claudio, for the results of these two clinical trials with CPICs in very high-risk AML patients. And I think to reserve the questions at the end of both presentations. And so let's move to the second presentation. And please, Francesco, with your presentation.
Thank you.
Can you all see my presentation?
Yes.
Yes.
Okay. Thank you, Dr. Galieni, for the introduction, and thanks to Professor A.Olivieri for giving me the opportunity to join this exciting meeting together with my mentors at the Acute Leukemia Working Party of the EBMT. It's really a great honor and a privilege for me. It's also quite a hard task to give a talk about frail AML patients, especially transplanting frail patients with AML, and late afternoon, actually, and also right after the Professor Martinelli and Claudio great talks about all the novel drugs in AML. So the huge developments in AML therapy, especially for older and unfit patients, and the design of novel reduced intensity conditioning regimens, together with the expansion of donor availability, thanks to the post-transplant cyclo platform, especially, and the recent improvement in supportive care are leading an increasing number of frail AML patients all the way to transplant. So I will quickly present 3 cases of patients who received transplant at our institution in order to address few practical questions that every clinician can face in the everyday practice. So case 1 is a frail patient who underwent an unrelated donor transplant. This was a man, 65 years old. It was diagnosed with AML normal karyotype with CPBA double mutated, so good risk according to ELN. And it came to transplant in CR2 with negative MRD. He had a comorbidity index score of 4+1 and a Karnofsky performance status of 70%. He had a 10 out of 10 unrelated male donor. So this case raises 2 questions. First of all, which parameters define this patient as frail, and what's the expected mortality risk? Further, what's the optimal conditioning for this patient? So as for the first question, patient fitness or frailty, if you prefer, it's a common matter of debate among transplant physicians. And luckily, we have scales, so we have objective measures to define patient health status. Different models have been developed, and I just listed here the most commonly employed in clinical practice. Mohammed Soro and colleagues designed the HCT-CI score about 15 years ago, and then revised it about 10 years later with addition of age about 40, which contributes the equivalent of a single comorbidity with a weight 1. Further, we should not forget about the ancient, I would say, measure of Karnofsky performance score, which is still a quick and easy tool to assess patient global health status. So in our case, we should take age, high comorbidity index score, and low performance status as parameters to define this patient as frail. You know, when the patient and his family are sitting in our room and we have this delicate conversation about transplant risk, we need these skills, so we need these numbers to properly counsel the patient. And actually, we would need even more refined tools to be able to predict the risk of mortality for each given patient. Here you see the groundbreaking work of Ronnie Chouval together with Acute Leukemia working party of the VNT, which was already shown by Professor A.Nagler. In this huge work, the authors identified 10 parameters strongly predicting mortality at day 100. And they derived this parameter by a machine learning algorithm. So it's easy for the physician, and you just go to the website, fill in the form, and you get the said percentage to be discussed with the patient. So for our patient, the HCT-CI score predicted a mortality rate above 40% at 2 years, and while the output of the EBMT ATD model was 27% at 100 days, which is remarkably high. You remember I talked before about Kanofsky performance score. It's simple and robust measure of patient global health status, and we performed this analysis, this registry study, including almost 3,000 patients with AML who received transplant in CR1 with a Kanofsky score which was less than or equal to 80%. Different donors were included, and the patient received either malablative or reduced intensity conditioning. As you can see, Kanofsky score was confirmed to be an independent factor for higher relapse mortality, no relapse mortality, excuse me, and inferior survival. Interestingly, patients with a mildly reduced score, so equal to 80%, did better with a myelablative regimen, while patients with a score below 80% had a better survival following a reduced intensity regimen. So this brings me to the next question raised by this case. What's the optimal conditioning regimen for this patient? Okay, so we define this patient as frail, and we all agree that we should choose a RIC regimen. But which protocol should we pick? The combination of fludarabine with reduced dose busulfan represent a paradigm of reduced intensity conditioning for AML. However, a recent randomized trial comparing trosulfan 10 milligram meter square 3 days to standard 2 days busulfan in combination with fludarabine showed an advantage in survival in the trial arm. So the authors advocate for FLU-TRAIL-10 to become a new standard of care for transplant in frail AML and MDS patients. So this story had a happy ending. Our patient received transplant in April last year, and we selected a FLU-TRAIL-10 reduced intensity conditioning and ATG, cyclosporine, and methotrexate as GVHD prophylaxis, a standard platform. And the clinical course was quite complicated, as you can see. However, the patient about 1 year after transplant is in CR with negative MRD, full donor chimerism, and no GVHD. So I moved to case number 2. It's a frail patient with high-risk AML undergoing haplotransplant. It was a man, 67 years old. He was diagnosed with AML harboring the 11q23 aberration, so poor risk. And he came to transplant in CR2 with positive MRD and with detectable MRD. He had a comorbidity index of 3+1 and a Kanofsky performance score of 80%. his donor was his male child, so haplodonor. In this case, the question is, what's the optimal conditioning for a frail, high-risk AML patient receiving an haplotransplant? So when we approach conditioning for modern T-cell replete haplo with post-transplant cyclo platform, we need to keep in mind this paper. This is like the perfect conditioning for a frail patient. It's well tolerated and it's a great regimen to just put the graft in. However, leukemia makes things always very difficult. And as you can see on the right side of the slide, this regimen was followed by a steep relapse curve. The addition of tiotepa to busulfan and fludarabine was initially published in the setting of cord blood transplant with the aim of developing a myeloablative regimen combining two alkylators. More recently, the TBF regimen was associated with low relapse rates and good outcome following haplo transplant. And this protocol can be easily adapted for elderly and unfit patients, tuning down the tiotepa and busulfan doses. The curves that you see on the bottom right side of the slide come from the paper by Dr. Bacigalupo group, and they show a promising outcome with low relapse rates, even in patients undergoing transplant with active disease. So back to our patient, he received transplant in March last year, and we selected a TBF-RIC regimen as conditioning, and the patient received post-transplant cyclone days 3-5 and cyclosporin mycophenolate as GFDD prophylaxis. The clinical course was really easy. However, as expected, the patient was still with positive MRD on day 30, so he received preemptive azacitidine, and we didn't give him DLIs because of a mild acute GVHD, and finally he got negative MRD at day 60. And last follow-up, which is about 1 year after transplant, is in CR with negative MRD, full donor chimerism, and no GVHD. So finally, I will present the case of a frail patient undergoing transplant with active leukemia. This is a 65-year-old lady who was diagnosed with AML MRC, complex karyotype, so poor risk, and she was refractory to CPX 351, and she came to transplant with bone marrow blast above 60%. She had a comorbidity index score of 2+1 and a Karnofsky of 60%, so frail patient. She had a haplo male child donor. So the question here is, what's the optimal regimen for a frail patient undergoing transplant with active leukemia? When we think about conditioning in active leukemia, sequential regimens come up. The group by Munich published this work about 15 years ago. This curve were shown also by Professor M.Mothy. This is a milestone in sequential regimen. This protocol was the combination of a cytokine reduction with fludarabine, emsacrine, and high-dose cytarabine with a reduced intensity regimen with low-dose TBI and cyclophosphamide. More recently, as previously shown, a sequential regimen including clofaramine was published, and this was specifically for refractory AML patients, so very difficult patients. And Professor M.Mothy and his group showed a promising outcome. And the same group recently developed a new novel sequential regimen for refractory hematological malignancies. This is very important because this protocol can be employed in the haplo setting. And this was something missing before. So given the lack of a comparison between different protocols, we conducted this survey. This is a recent publication comparing 3 regimens, Flutrail, TBF, and Flamza on almost 900 patients. And outcome was actually quite dismal, as you can see. However, Flutrail and Flamza seems to perform better as compared to a standard myeloablative regimen as TBF. So back to our patient, she received transplant on December 2019, and we selected a sequential regimen with cytarabine, idarubicin, followed by fluoxetine TBI to gray, and the patient received post-transplant cyclo on days 3 and 4, and tacrolimus mycophenolate as GVT prophylaxis. The clinical course was extremely complicated in this patient. However, she got a CR still with MRD. She received preemptive azacitidine and dialyze, all that we gave her. However, unfortunately, she relapsed quite early, like day 90 after transplant. And unfortunately, she died about 10 months after transplant. In conclusion, with current AML therapy, a significant amount of frail patients reach a CR, and an allogeneic transplant is often considered. However, transplant in frail AML patients remains a huge challenge, and prognostic models could help in selecting patients and tailoring transplant platforms, and conditioning intensity should be mitigated as much as possible, but relapse remains the main issue. Modern peri-transplant strategies should be employed to reduce relapse rates. We have a dream to get the perfect balance between old toxic drugs to be given at the minimum necessary dose to guarantee engraftment, and novel target therapies to be employed before and after graft infusion in order to get the most out of the unique immune platform of allogeneic transplant. Thank you.
Okay, thank you, Francesco. And are there any questions? If not, I would like to perform a question to Francesco, and thinking that all the patients with AML easier find an haploidentical donor, and so they are frail. So, and in your center, is there a standard platform conditioning regimen for frail patients with AML, which are transplanted, which have to be transplanted?
Thank you, Dr. Galieni, for this important question. Actually, yes, we try to be homogeneous as much as we can. For frail patients, AML patients undergoing transplant in CR with MRD, we use the TBF platform. So TBF with 2 days busulfan, because the data of TBF with 3 days busulfan, this is actually a much heavier conditioning. And Tiotepa, actually, it's the original protocol was with 10 milligrams Tiotepa, but actually there is recent evidence that probably giving just 5 milligrams doesn't make a difference. So this is actually our standard protocol is TBF with 2 days busulfan and Tiotepa, either 5 or 10 milligrams. Post transplant SAG, we give on day 3 and 5 with the day of rest, as like in the European fashion, let's say.
Okay.
Yeah, I'd like to comment on this. I mean, first of all, to congratulate Claudio and Francesco for a really fantastic, comprehensive overview. But I think it's important to all our colleagues that we looked more and more, because we've been using this Tiotepa-based regimen, TBF or other Tiotepa combination. And because we combine them with other alkylating agent and we use post-Cy, which is an alkylating agent, we are generating a lot of injury to the gut. and the lesions in the gut are really initiators of severe gut acute GVHD. So this is why I would like really to support what Francesco is alluding to, is that it is recommended more and more to decrease the dose to 5 milligram per kilo total dose instead of the original publication of 10 milligram. And we have seen, we did this comparison, you have a significant reduction in toxicity. And I think this is really important to all of us.
Okay.
Question in the chat. Can you see it?
Okay, I'm reading the question. Is there any evidence that peri-transplant target therapy, IDH1, 2, and F53, can actually select non-responsive clones? I don't think that we came to that evidence still. Maybe with accumulating experience with this target therapy, we'll have more data about resistant clones, so leukemic clones which are resistant to this target molecules. I don't think that so far we can make any conclusion about this.
Yeah, I agree with Francesco. I think that collecting data widely from our country, but not only data from the real world experience, maybe we can also find answers and to find the room for improvement with pixels-based treatment. I think that with improving the registries, we can select also these subcategories in order to find the best way to select or not select responding clones and to better improve the bridge to transplantations.
Okay. Other questions? If not, I'll move to Professor Olivieri for the conclusion of the meeting. And thank you again, Attilio.
Thank you. Can you see I have very few slides in order to comment this very exciting meeting, and let me thank all the participants. More than 80 participants have been registered in this very important achievement for this meeting, and let me thank also the faculty, particularly M.Mothy, A.Nagler, G.Martinelli, Jets company for supporting this event, and Pro Eventi for very good organization. So very few minutes in order to give you some comment. As you know, this statement is not only a slogan, but is a real life, because as you can see in Italy, but I think also in Europe, in other countries, haplo transplantation with post-transplant cyclophosphamide represents 1/3 of the total of allogeneic transplantation. And as you can see here, an important observation is that the incidence of chronic GVHD in patients receiving the post-transplant cyclophosphamide platform seems very good, significantly inferior compared to the conventional platform. But please keep in mind that is a retrospective comparison. Despite the very high number of patients, you should compare in a prospective way, in a prospective fashion, haplo with conventional approach, particularly considering the difference, because I'm convinced that bone marrow source is not the same of peripheral blood stem cell source, as Mohammad reminded in his talk. So also the harvest quality does matter. This is a very old study showing that the quality of bone marrow harvest is very important in predicting long-term outcome, and this is particularly important also in the setting of haploidentical transplant. So finally, do not forget, we particularly focused on the pre-transplant and the immediate after transplantation scenario, but those patients have the long-term survivors have often late effects that can impact in the long-term outcome, not only chronic GVT, but also secondary solid malignancies and other kind of late toxicity, cardiovascular toxicity, pulmonary toxicity, affecting both quality of life and financial problem. So in conclusion, we have a very exciting perspective in order to lower the non-relapse mortality, particularly in older patients, as Francesco Saraceni showed us, and we have to work hard in order to reduce the incidence of chronic GVHD, and the still higher incidence is a real challenge. So let me thank everybody, the faculty, speakers, and arrivederci.
Thank you.
Thank you.
Thank you.
Thank you very
Thank
much.
you.
Well done. Congratulations.
Congratulations.
Can I ask, I have a question for Mohammed. Can I, even if at the end?
Yes, please.
If now, if you could choose between a MAD donor or haplo donor for a young or older patient with AML, considering times, costs, and everything, which type of donor would you choose?
Excellent question. I have two answers to this.
Sorry for the time.
No. The first answer is the official answer. You know, if a judge is asking me this question, I will say we don't know, because we don't have the famous phase 3 randomized trial comparing yet. Then the second answer is my experience as a clinician doing this. We started our haplo program using post-Sci in 2006. So we have accumulated some, and at this time in 2006, I can tell you, everybody thought that giving cyclophosphamide was crazy. And actually, I have just only copied what Luznik and Paul learned with them from the US when I was visiting in 2005, 2004. So now I wouldn't hesitate to take a haplo donor. We don't wait for the unrelated donor. But this is the non-official, this is the empirical, I would say, practicing answer.
Thank you, and sorry to everyone. Bye-bye.
Bye.
Oh, thank you again to everybody, and so I hope to see you in the real life, not in the video, in the screen.
Yes, please.
Bye.
Bye.
Thank you. Bye.
Bye-bye.